My name is Sheila Rosenthal on behalf of Greater Lafayette DSA and other healthcare advocates working for healthcare for all as a human right. We're glad to have all of you here with us. I'm a retired registered nurse. I grew up in New York City, moved to Indiana a little over 30 years ago with my husband, Frank, when he got a job at Purdue. We raised our 4 sons in Indiana. I got started with social justice as a new nurse, organizing an independent union for the nurses at the hospital where I worked, and have been active in different kinds of issues, social justice issues, and my background in nursing, which I've continued for the last 45 years, has combination of those has brought me to work on this issue. The purpose of this town hall is to talk about these issues in some greater depth with both some healthcare professionals that will share their personal experiences, and also some organizers, and some of the speakers are both healthcare professionals and been organizing for Medicare for All at various levels. For the most part, we're focused on this issue in the state of Indiana, and our campaign particularly is in Tippecanoe County, but we're glad to have some people from other parts of the state because, as maybe Rob will talk about, the Medicare for All Indiana group is trying to coordinate across the state, and I think that will help us to be more successful. So I think our program was shared, and I'll just briefly go over it. We'll have the speakers that we'll have, and we'll start off with Jim Nolan, who's a grad student in biological engineering at Purdue and the chair of our Medicare for All Greater Lafayette DSA committee. Dr. Rob Stone was born and raised in Indiana. He worked in emergency medicine and is the medical director for palliative care at IU Bloomington, and has been working on this issue for many years in Bloomington, and leads the Medicare for All statewide group. Lucy Bruce Whitaker is an RN born and raised in Jasper, Indiana, worked for 33 years in ICU, and is currently a school nurse and works part-time in the ICU. Riley Braun is an NNU organizer and will talk to us about the national Medicare for All campaign. Dr. AJ Sinha grew up in West Lafayette, graduated from Purdue, and is working as a nephrologist and on the faculty of IU Medicine. And James Blanco, we expect to join us, who's a recent city council member in West Lafayette.
I'm right here.
Okay, great. Hi, James.
Hello.
After all our panelists are finished speaking, we'll give them 10 minutes to react to each other's comments, and then we'll open up for questions. And so I think with that, we're going to have Jim start us off to talk about our Medicare for All campaign in Greater Lafayette DSA.
Thanks, Sheila. Yeah, so Sheila said I've been working with her on this campaign, and so thanks to everyone for joining. Our other speakers will talk more about the specific need for Medicare for All, and especially in Indiana. But I think more than ever during this pandemic, like, we've seen how broken our healthcare system is and how much we need Medicare for All. So even before the pandemic, there were 30 million people who were uninsured, and 30 million people about who were underinsured. And those of us with insurance bear increasingly unaffordable premiums, deductibles, and copays. And then during the pandemic, more than 5 million people have lost their health insurance. And so why is that? Basically, the health insurance companies are making record profits. Health insurance CEOs make over $20 million a year on average. And the administrative bloat of health insurance companies is obscene. About about 30 cents of every dollar spent on healthcare in this country goes to the for-profit insurance industry. And I'm sure most of us have either like experienced this broken system firsthand or know someone else who has, that it's either introduced stress into our life. We've had trouble paying premiums or co-pays. We weren't sure if we were able to like afford treatment for a serious medical condition, and or we've been stuck with the job because we're afraid of losing our health insurance. So the solution to this unacceptable situation is Medicare for all. The elite leaders of the Republican and Democratic parties have been completely incapable of providing solutions. It's no surprise then that a majority of Americans support a federal single-payer healthcare system like the Medicare for All Act of 2019. So now I'll share my screen. Let's see. To explain, so what does Medicare for All mean? It means a single health program. So everyone's covered by one health insurance program that's administered by the federal government and have equal access to the medical services and treatments. It's comprehensive, so that includes dental, vision, mental health, and pharmaceuticals. It's free at the point of service and with universal coverage to all US residents. And finally, it has a jobs for just transition. So jobs initiative and severance for those affected by the transition to government-run healthcare. On top of that, we're also campaigning for something called the Healthcare Emergency Guarantee Act. Sorry, I'm having some technical difficulty. Oh, okay, here we go. Which is introduced by Representatives Pramila Jayapal and Senator Bernie Sanders. And it would expand Medicare to cover all uninsured Americans for the duration of the pandemic. And it would also empower Medicare to cover all out-of-pocket costs, even for people who already have health insurance coverage. So, and that's all nice and good. And, you know, if you've seen the polls, like about 70% of people support at least a government-run healthcare program. But what's it going to take to actually win this? And it's going to take a mass approach to political organizing. We know that it's a remarkably popular program, but we need to kind of change the passive support and convert it into active support. And we're going to do that by, as DSA, by canvassing, tabling, talking to people about their healthcare woes and how Medicare for All is a solution. And also, you know, not to be too down on myself, but we can't build this movement just on like well-meaning college students like myself, even though we'd like to help. It's going to have to be won by like the entire working class. And so that means we're going to have to get beyond our typical activist circles and reach the working class majority wherever they are and get them engaged politically. And that's like the point of this mass approach to political organizing. Right now, we're building momentum by campaigning for city council resolutions in Lafayette and West Lafayette to pass resolutions urging the upcoming Congress to pass the Healthcare Emergency Guarantee Act and the Medicare for All Act. With that said, okay, so if you live in or around Tippecanoe County and haven't already signed our petition, please do so at medicareforall.gldsa.org and share with your friends and family. In addition, we're collecting healthcare testimonials to share at city council vote meetings. So if you would like to share your story of navigating our broken healthcare system, please let us know by signing up. Then we'll be organizing a large event in January leading up to the city council vote on the resolution. And we'll need help either writing a letter to the editor or mobilizing our supporters through a phone bank to call city council. So you could use this link, act.gldsa.org, to sign up for that. Something like phone banking may seem intimidating, and I'm not the most extroverted person, but like after the first call, it's really not so bad. And if you have a busy schedule, we can help you set this up so you can do it at your own time. And then you see on the right, we've been doing regular in-person canvassing, and now that it's cold and the rates of COVID have been going up, door flyering. So our next flyering is Saturday, December 19th, with the location to be decided. And you could also sign up for that at act.gldsa.org. And then finally, before we move on to the speakers, I'd ask you to join DSA. So I joined because this is where the action's happening as far as mass organizing. We're the largest and fastest growing socialist organization in the country. I think at the moment we have over 80,000 members. And the best part is we're a member-driven organization, which means we democratically decide what to organize around and how. So you can become a dues-paying member of DSA at the top link and get involved with their local chapter at the second link.
Okay, so Rob, I think we're ready for you.
So I'm happy to be here. My name is Rob Stone, and I have got a couple things to say. Hopefully you won't have to give me the hook because I can get kind of long-winded. So anyway, I give a talk every year in August to the first year medical students, the new crop of students who are from IU School of Medicine on the Bloomington campus. And so this August, when I talked to them, this is what I said. I said, I started medical school in August of 1973. So that was 47 years ago. It's tempting to talk about all the changes and technologic breakthroughs since then, but instead, let's talk about the one thing that has hardly changed, which is the way we pay for medical care. In 1973, we had Medicare, Medicaid, the VA, the Indian Health Service, private health insurance, usually provided through somebody's employment, and tens of millions of uninsured. And these programs are all a little bit different. Medicare is probably the best care you can get in the United States, but the VA provides really great care too. It's not quite, it's a little bit different system. And so both of them really provide better care than people who have private insurance. And then if you have Medicaid, it's really hard to get good care. But if you have no health insurance, then all you can really do is hope that you don't get sick, because you'll get sicker and sicker and you'll be you'll be financially wiped out. So what I'm describing is a medical caste, C-A-S-T-E system, not a medical care system. And the uninsured are like the untouchables. And so I'm going to do a little bit of screen sharing here, and let's see if I can make this show you a couple of slides here. And we'll go here and here. Is that there for everybody?
Yeah.
Okay. All right. So so we've got really big problems with our healthcare system, and we got to try to figure out how we're going to fix it. And nobody says it's going to be easy, but a couple things that Jim mentioned that caught my attention. I love talking to well-meaning college students because they're great, and they will talk to other people too. This is a really popular program with the public. And so let's take a minute to look at this poll. Now you may have to move your where you've got your pictures of people around a little bit to see this whole slide. But this is from election night, and this, or maybe the night after the election, and this is on Fox News. And so what are they saying here? National voter analysis, changing to a government-run health plan, strongly in favor, 39%, somewhat in favor, 33%, somewhat opposed, 14%, strongly opposed, 15%. So that adds up to 72% in favor, 29% against, and then the other people are kind of in the middle or can't make up their mind. So what does that mean? So let's look a little bit more at, oh, you know what, with the screen share. Oh, there it goes. Okay. So that means, so this was a big study, 109,000 voters conducted over this time period, October 26th, November 3rd. The University of Chicago put this together. And it was pretty reputable, and the way it was done, even though Fox News commissioned it and paid for it, it looks like they actually stayed out of it, and you know, they don't want these kind of numbers out there. And it was pretty evenly split, male, female, young, old, urban, rural, Democrat, Republican. So this is an idea that people that resonates with people. People really want to figure out how we're going to take care of everybody. But then, you know, what about this government-run healthcare? That kind of sounds a little scary. I mean, Jesus, I hope you're not going to say this is socialism or something like that. Let's think about what this really means. So this is a map of the world. And as you can tell, the countries in red are the communist socialist. Oh, excuse me. I'm sorry. My mistake. The countries in red in this map of the world are countries that have no universal health care. And you see that, I don't know if, I think you can see my cursor. There we go. So the United States is in red, parts of South America, Africa, Asia, Indonesia. The United States really stands alone as the only first world country that doesn't have universal health care. The countries in blue and dark blue are countries that have universal systems. They take care of everybody. And some of these systems, like in Brazil, are underfunded. You know, they're not as good as the system in Spain or somewhere else. But these are countries, and then in light blue are countries that are actively trying to build universal systems. So Mexico, for instance. And so the United States hasn't even made a commitment to cover everybody, and Mexico has. They're trying to figure out how to do it. And then the countries in yellow over here, Iraq and Iran, Iraq and Afghanistan, are the countries that the United States set up national universal systems for as part of the war effort. I think they've kind of fallen apart right now. So every country in the world, the government plays a big role in healthcare. And in the United States, taxpayers fund about, when we talk about all those different programs that we have in the United States, taxpayers fund about 65% of our whole healthcare system. So the government has a lot to do with healthcare in our system. And so if you're like me, if you're over 65 and you have Medicare, then that's as if I lived in Canada, because Canada has a system very much like our Medicare system, except for in Canada, you get into the system at birth, not at age 65. They call their system Medicare. And we can talk more about that later if you got questions about the Canadian system. Now, if I had VA coverage, then that would be as if I lived in Spain or England. Because in Spain or England, they have systems that are much like our VA in that, by that I mean that in those countries, basically the government owns the hospitals and the doctors and nurses are employees of the government. So that's a system like our VA system. So that's another way governments get involved in healthcare. And if you have employer-based insurance, then that's like you lived in Germany. Because in Germany, insurance is through your employer, but there are a couple huge differences between the German system and the American system, because first of all, everybody's covered in Germany. Everybody's covered. And the second is the insurance companies are not for profit and they're heavily regulated by the government. And so what is it if you have no insurance? Well, then you're in Angola or somewhere in the third world, because that's what you get in the United States is you get third world healthcare if you're not if you don't have insurance. So that's kind of where we are. We've got a system that is multiple systems. It's fragmented, and we're looking for a single program. It's really not very comprehensive. And there are lots of financial barriers, so it's not free at the point of service, and it's not covering everybody. It's not universal. So we've got to fix this. And so what could be standing in our way? It makes so much sense. Well, this is a cartoon from years and years ago. The insurance companies are a major barrier to what we're trying to do. And so obviously the patient says, "Doc, can you see the problem?" And the doctor says, "I'm afraid so." There's a huge middleman that is sucking out money and adding hassle. And basically the insurance companies are torturing patients and torturing doctors. And they're incredibly unpopular. If you ask people actually, if they like their health insurance, then a lot of people will say, "Oh, yeah, I love my health insurance." But then you ask them the follow-up question, "Well, have you ever been sick and you had to need to use your insurance?" And the people who love their health insurance company usually are the ones who've never been sick and never had to use their insurance company. So anyway, we got to figure out how to get rid of these guys. And and Jim mentioned that they're very profitable. This is actually about my last slide, because slides this time of night sometimes can put people to sleep. But so here's a slide. That's a pretty new slide. COVID-19 boosted insurers' profits. This is all from SEC filings. And so what we got here is Centene, Anthem, Humana, Cigna, Aetna, and United Healthcare. These are the 6 biggest insurance companies, private insurance companies. And so what we got in the kind of turquoise teal color, there is the second quarter, Q2 of 2019. And then in yellow, we've got Q2, the second quarter of 2020. So the second quarter of 2020 was April, May, and June of 2020. And what you see filed with the Securities and Exchange Commission is that the insurance companies had huge increase in profits from that same quarter the year before. And I guess I can't really wait for I can't ask the crowd to answer why, but some people would know. But the reason is, this was when the COVID shutdown was going on. And so things like elective procedures in particular, things like colonoscopies and breast biopsies and elective joint replacements and surgeries and stuff, all this stuff was put on hold during those months. Because the hospitals were gearing up and trying to not be overwhelmed and protecting all their personal protective equipment and all that sort of stuff. So lots of healthcare was not delivered during those months. And as a result, the insurance companies they kept getting the premiums and they didn't have to pay anything out. They had a huge windfall. It's not talked about very much. And there's been no effort that I've heard of to actually get them to pay it back or to give it back to us. So that's kind of where we are. So what I think we ought to do is, we've got this Medicare program. It's over 50 years old now. And Medicare needs to be protected. It needs to be improved, and it needs to be expanded. So that's what we're talking about on this side. Medicare, as American as apple pie. So it doesn't matter to me whether it's socialist or not. It's a totally American idea. And then our group in Indiana is called Medicare for All Indiana, and we work all over the state. But it's really hard to organize these days, as everybody on this call knows. We used to do tabling and all sorts of stuff you just can't do anymore, but we're still working, and we're doing stuff on Zoom and whatever we can. And it's going to be a really interesting road from here, but it's so crucial. It's so important. And what we're doing now is immoral and unaffordable, and just plain wrong. That's what I'm going to end my screen share.
Great, Rob. And so we'll just turn it over to Lucy, but I failed to say before that anyone who wants to can put their questions either in the chat here on Zoom. If you're watching on another platform, put your questions in there, and we'll be collecting them all from all those places for the end after when we're ready for our Q&A. And also we were going to let people know that there will be a recording of this session. So if you know people who weren't able to be here, we'll be able to share the link for the recording. So now we'll hear from Lucy.
Okay, I'm here with my story. Like Sheila said, I've been an ICU nurse for 33 years. I still work in an ICU on weekends when I'm not at the school, managing quarantine and COVID isolation for the students and the staff. But several years ago, before the Affordable Care Act was passed, and before we had full-time doctors around the clock in our ICU, I usually go to work at 3 o'clock in the morning, and I'd gone in and we were getting an admit from the ER, and this patient was so critical that the ER doctor had already spoken to the intensivist, and the intensivist beat the patient to the ICU, and we were all waiting in the room. And this was a young person under 26, who had been at home and had been sick for like a week, but didn't seek medical care because they were afraid of having a medical bill that was too big to pay. They had a lower paying job that didn't offer health insurance. And they felt like, they were young and pretty healthy, and that they would be able to, get over this flu or whatever they thought they had. And what they really ended up having was they were septic. And I don't know how many of you have ever done CPR on a person, a real person, not a mannequin. The patient got to our unit and was not there for more than 5 minutes, and we were coding this young person. We have nurses, the doctor, respiratory therapist, everybody taking turns, the crash cart, bags of fluid being pushed in, medications being pushed. And we still are, but back then, if we had a patient that coded before a doctor got there, the ICU nurses are ACLS certified. So there's a protocol we can follow that has step marks going down, and you do this if the patient's this rhythm or this way. And, we had been coding this patient for an hour, and, we're all looking at each other, and the room's a mess, and there's things thrown everywhere, and saying, okay, is there something that we could have, something else we can do? Is there something else? And, still taking our turns, doing chest compressions, changing out on bagging the patient so that they get air ventilation. And finally, after going through this scenario for many, many times, saying, is there another thing that we can think of? Is there another thing we can try? Pushing another med, pushing this. And just the doctor said, we have to call it 24 and a half years old, and this is time of death. And our doors in our ICU room back then were glass and broke open. And when we were all done and looked up, someone had let the parents in, and they were standing watching us code their child. And they were standing there clinging together, sobbing. And I know in my heart, because I had kids about that age, that I would have paid anything, any medical bill. I would have sold my house, anything to save my kid's life. And they didn't have that opportunity. This young person was denied his life because of fear of having a medical debt that was so big he would never get out from under it. And I don't believe that we live in a country where this should ever happen. And I've watched it happen time and time again. I had a coworker whose daughter had a brain tumor, and they ended up, she was a nurse. She didn't work full time. She worked, probably 6 days out of out of 2 weeks. And her husband was a realtor, and they ended up selling their house to help pay for treatment. And, you know, as is sometimes happens in cancer stories, their daughter didn't survive, but they lost their house paying for treatment. And it's wrong to be in the United States of America and have to choose those things. It is just morally, ethically, spiritually wrong. I still work in the ICU, like I said, every other weekend. And I'll tell you that the pandemic is killing us. It's killing the nurses also, but the patients that come are sicker. And I think that education, I think that universal health care will help us educate the public, because they don't understand COVID. We still have COVID deniers, and it makes treating them so very difficult when they don't believe that they have the virus, and they don't believe in the things that have been so far proven to improve their outcomes. So I think that not only caring for people, but I think it's also a chance to educate them and make them better keepers of our own health. And I've already cried, so I really don't have anything else to say right now.
Okay, thank you, Lucy. Glad you could be here. I guess we're ready for you, Riley.
Wow, what a story to follow. Thank you, Lucy, for sharing all that. Everybody, and thank you for your time as a nurse and coming back as an ICU nurse and putting in time like that. Sheila, also thank you to your time as being a health professional, and everybody else who's on this call who's a health professional or is a nurse or is on the front lines protecting us against COVID. I can't tell you how grateful and appreciative I am to be here in space with you all and for the work that those folks do. But anyway, my name is Riley. I work as a community organizer for the National Nurses United on the Medicare for All campaign. A little tiny bit about me. I got my start in organizing back in 2016 on the Bernie 2016 campaign, later became a delegate to the DNC, later would organize with Portland DSA on their Medicare for All campaign. And I'm still an active member in DSA and have, in the last few years, started working for the nurses on this issue. And, the nurses decided, as you've heard on this call, long ago that the most egregious part of our healthcare system is the fact that it is for profit. Lucy shared one, particularly egregious example, and there are thousands more just like it. People getting denied care, people losing their homes, losing their retirements, their savings, everything over the costs of healthcare. If you ask me, I am of a socialist belief, and I definitely believe what's been happening in Rob's mind, as he kind of alluded at it, is just wealth extraction. There's been wealth extraction happening by the for-profit insurance companies since the post-World War II era. And since its existence, and we should think about it like that, and we should articulate that to others, right? If it's difficult to talk to your grandparents about Medicare for All because it's a socialist idea, maybe talk to them about Medicare, maybe talk about Medicare Advantage and the extras they have to pay. I'm not here to talk to you all about that. I'm here to quickly talk to you about our Medicare for All campaign, and I'll share some links in the chat for you all. But so our campaign, we launched it back just post the election. We've been working on Medicare for All, for decades, but this particular iteration of the campaign, we are launching for this new congressional session. We launched in November. And what we are doing for this new launch is we are asking everyone everywhere to become district leaders. And we are hoping and district leaders organized by your congressional House district. And what we are asking these district leaders to do is to hold a legislative visit with their member of Congress to ask them to be an original co-sponsor of the bill. And if that sounds scary to you or sounds like something that you have never done before, don't worry. There are people like myself that are able to help you walk through this process. We have guides and all sorts of different stuff to help support you in that work. So if you are at all interested in working at the national, federal level, or working on your particular member of Congress in the House, please do reach out to me. I'll share my email in the chat, and I'd love to get you connected to our district leader program. And as we do this, you know, it sort of serves many purposes. The first and foremost is just to make the ask to the legislator, right? You'd be surprised, but this last congressional session, there were actually a couple representatives that told us, like, oh yeah, like, thank you for sending some constituents to ask me. Like, no one had asked us about this bill before, so, you know, we signed on. And not every rep's going to be like that, right? But we did get a couple just from doing that. And at another level, you know, what this does is it shows the congressional representatives that there are individuals and constituents in their district that care about the issue and that are working for it, right? And the more sort of work that we can generate around Medicare for All, the more that we will ultimately be able to get friction on the bill to pass. I'm sorry if I'm running close to time here. So the district leader program is one thing that we're doing. We're also going to have a massive day of action around the introduction of the House bill that will be sometime in late January or February. So keep an eye out from that for us. And I'm sure that I will share it with Sheila and other folks on this call who will disseminate it out and down. But yeah, look for that. We'll do a big national day of action. Yeah, that's pretty much the things that we have in store right now. We're also going to do, we're developing a leadership school. This will be pretty cool and interesting and new. You know, we realize that in, you know, doing this work for a while now, that one of the sort of best things we could do is to give organizers everywhere a sort of 101 training that will give people like a background of how to have an organizing conversation, a background of like how to curate a list, a background of like how to power map your legislators and power map your city hall council members and things like that. So we hope to give organizers and activists a little bit more in-depth training and tools and skills to do that level of work. And so we'll be introducing that in the next few months as well. And we're going to do it very small, you know, 30 to 40 class sizes. We'll do many iterations of it. It's being developed by our national union's research and education department. So it's like real academic thinkers are going into it, not just us organizers who want to organize everything. So we're going to have some true content in there. But yeah, I'll be sure to share my email in the chat. So if you're interested at all in getting involved in the district leader program, please reach out to me. And I'll also just generally share our website in the chat as well. If you just go to our website and you've never been there before, there's like a pop-up and you can sign up for our just like general email list, so you can keep up with what the national campaign is doing. But yeah. If I had more time, I'd delve into a bunch more stuff, but thank you.
Yeah, well, maybe we'll have more time during the Q&A. And just before I let you go, AJ, I'll just say a word that you didn't say, Riley, about NNU. As a nurse, I've appreciated the work, and maybe a few others on the call are aware of. NNU is among a few unions who have really taken up progressive issues, have organized their members as well as beyond to issues such as patient-staff ratios, and now recently, the last few years, Medicare for All, and they've been a true leader in the progressive movement. We'll be getting to talk more as we go. So go ahead, AJ.
I'm next up in the queue.
Yeah.
So I'm AJ Sinha, physician in Indianapolis and a Central Indiana DSA member. I'd like to thank the Greater Lafayette DSA folks for inviting me to speak. I'm going to provide the usual disclaimer that I don't speak for my employers or the university or the VA where I work, because I want to keep my job. So I'm speaking for myself and my activist organizations as a member of those. So Rob talked about the big picture, and Lucy gave a great personal story. Which is heartbreaking. I wanted to focus on a couple other points that are just based on just personal experiences of mine as a physician in Indiana and Indianapolis. 2 points. One is just the lack of stability that our current system has. We talk about the tragedies. We talk about how Medicare for All will, get rid of copays and premiums. That's all great. That's fantastic. But there's a lot of other implications about our current system and how it's failing us, and how Medicare for All would be better. Number one, I want to address lack of stability. Number two is the racism of our current system. So for the lack of stability, it's illustrated by one of just a patient encounter I had, Black male, early 40s, so similar age to me when I saw him in the hospital. It's not at the VA, it's at the county hospital. And he was recently imprisoned, and he had been in prison for a number of years, had stable chronic medical conditions, was seeing one of my colleagues. But when it came time for him to be released, he didn't have a job. He'd just been locked up for years. And he didn't have health insurance set up. So suddenly he gets released, and he doesn't have money, didn't have insurance to cover doctor visits with my colleague or his other physicians for his chronic conditions that were well controlled, and he didn't have money for medication. So his easily treated but chronic and serious conditions became decompensated. He got sick and he got hospitalized. He just clearly fell through the cracks because we don't have a comprehensive system or universal system. Another example is, these are both within the last year, I've seen these folks. Another one, it was a around 30-year-old woman, longtime patient of mine, who was pregnant, had recently been laid off from her job. She'd actually told me, well, when I was visiting with her, that she actually trained her replacement, and then she was laid off, and so she didn't have health insurance. She was seeing me. She has, a non-trivial kidney disease. I'm a kidney doctor, but we had to delay getting tests because she didn't have health insurance. And again, it's because we have this balkanized system that is a patchwork and fractured, like Rob illustrated, that she didn't have coverage then at that particular time because of the precarious nature of our whole system, not just healthcare, the whole system in this country. But in my eyes as a physician in healthcare, she's falling through the cracks. So those are just two examples. Another one, I do mutual aid organizing and activism with Indiana Insulin for All. And so I've met a number of folks, in particular type 1 diabetics, that if you have type 1 diabetes, you don't get insulin over a matter of day or two, perhaps longer, depending on other factors. You can get something called diabetic ketoacidosis, a very high acid level in the bloodstream. It can be fatal. And so because of the instability of our system, the potential loss of health insurance, or even if you have health insurance, the cost of these drugs in our system can be prohibitive for folks, so they don't get the insulin they need, or they try to ration their insulin, and if they get any sort of, things may be going okay while they're rationing, but if they get a little sick with whatever, something that someone like me who's otherwise healthy might feel a little ill, but otherwise fine, if they get it, their insulin requirements go up. And since they're rationing, they're already lowballing their insulin dose. In this scenario, they get diabetic ketoacidosis, get very sick and hospitalized, or they can die, of course. And then there's a man I've met locally. So this is not as in my wearing my hat as a physician, it's wearing my hat as a socialist and activist. There's a man locally who has type 1 diabetes, middle age. He had a son with type 1 diabetes who, because of the cost of the standard of care insulins, which have been around for over 20 years, but they were very expensive because of our profit-driven system. This man's son with type 1 diabetes changed to the cheaper, older types of insulin, and those are harder to dose and to manage. And because of that, he accidentally overdosed and died. And so he lives locally. So that's and this was just summer of last year that this happened to his son. And again, our system's unstable. If we had a universal system that covered everybody, then if you leave prison, if you're in prison or not, doesn't matter, you're covered. If you're a pregnant woman getting laid off, doesn't matter, you're covered. We wouldn't have these tragic cases. Or if it was comprehensive and insulin were covered, then we wouldn't have people rationing or overdosing. Okay, I want to touch on racism. Of course, I don't think anyone disputes we live in a racist country. But with the abolishment of de jure racism, I guess with the ending of Jim Crow, racism manifests largely, can't be in name, but it's in practice, building cracks in our society and then making black and brown, other oppressed or criminalized people fall through those cracks. And when it comes to our balkanized system here in the United States, a healthcare system, those cracks are made quite wide. And so black, brown, indigenous folks are the ones that fall through. And so, of course, I give the example of the imprisoned man. It turned out he was a black man. Black folks are most likely, far more likely to be criminalized or to not have, to be underemployed or unemployed, have little wealth, so they can't afford the copays and deductibles, et cetera. And so our system with its cracks is inherently racist. But personal experiences include, as a nephrologist, a kidney doctor, seeing undocumented patients here in Indianapolis who have kidney failure requiring dialysis, which is a form of life support. In the United States, it turns out that current Medicare is the major payer for dialysis. But if you're undocumented, you can't get Medicare, so they can't pay for dialysis. And so these folks have a universally fatal condition that can, and there's a treatment that can keep them alive, dialysis, but they can't get it the normal way, which is to have a dialysis clinic where they go and get dialysis regularly to keep them as healthy as possible. Instead, they just show up to the hospital when they're super sick, and if they're on death's door, then they can get dialyzed, and they dialyze so they don't die that day or the next day, and they get sent out, and then they come back in a few days when they're on death's door again. And that is inherently racist, as you can imagine, because the undocumented people that are coming to this country that need dialysis aren't Europeans. They are generally, darker complected. So generally it's people from south of here, so in Central or South America. If we had a comprehensive system that covered dialysis for everybody, all medically necessary treatments, and a universal system that covered everybody, if you're a living person in the United States, then this inherently unjust and racist system would be made a little bit more light, a little bit less harsh. I'm not claiming that Medicare for all, improved and expanded Medicare for all would be a panacea, but it's a necessary but not sufficient step to address the racial inequities and injustices in our country. I think I'm close to my time, so maybe I'll leave it there. And I'm glad we have a lot of time for question and answer, so I'll leave it at that.
That sounds great. I just wanted to say before we go to James Blanco that the organizations that have endorsed Greater Lafayette DSA's Medicare for All campaign so far are the Younger Women's Task Force in Greater Lafayette Immigrant Allies, and Greater Lafayette Indivisible. And we'll be continuing to do more outreach as we continue on. Also, after James speaks, we're going to have 10 minutes that we can use for panelists to respond to each other. And then we'll get into the questions that have started to come in the chat, as well as probably coming in from the other platforms. So we'll give next James Blanco.
Good evening, everybody. So I'm on the City Council of West Lafayette, so I'm one of the new members. I mean, this is the end of my first year in office. So a few of you, like Sheila, would know me, but I was active in the Democratic Party even before running. But so this is one of the issues that's been pretty important for me, because even members of my own family have gone into medical debt due to our system. I have medical debt. So it's something that I consider even a personal issue even before I was an elected official. It was something that when David Sanders was saying that you guys were creating a draft resolution on this, I'm on board. So a couple of pro tips I would think of to maybe improve your outreach. You can look up our emails. So on westlafayette.in.gov, that'll be for the West Lafayette City Council. And a pro tip if you have your story, you have your reason why you support it, like make it personal. Like that makes something that I think that would be a big help in trying to persuade a lot of the fellow members. We have David Sanders and I mean, we're both pretty passionate about this issue, but we want to make sure that the whole Democratic caucus is on board at the end of the day. But yeah, I gotta say though, it's good to be here. Good to have you guys have this together. And this is gonna be it's not gonna be easy, but I think we can push it through the West Lafayette City Council at the very least. I think we have a good shot because we have energetic new members. We have me, we have David Sanders. I'm pretty optimistic, but nonetheless, it's going to be a fight, and it's not going to be easy. I'll tell you that. But I'm with you nonetheless.
Okay, thanks, James. If the panelists would like to respond to what other panelists said, we'll take some time for that. So if there's someone that would like to make some comments, why don't they raise their hand or put it in the chat that they'd like to say something. Go ahead, Rob.
So I think it's worth spending a little bit of time, but again, hook me in, or put the hook on me if I get too long-winded about this thing called the public option. It's really misunderstood, and I just saw that Riley put a link to the NNU position. And I just glanced at it, and it looks like it's completely what I agree with, which I'm not surprised about at all. So, but here's my quick story. We do a radio program here in Bloomington once a month called Prescription for Healthcare, and we've been lucky enough to interview some people around the country. And so last week we were interviewing a man in Colorado named T.R. Reed, who some of you may remember. He was a correspondent for the Washington Post. He was on NPR for years. And then he wrote a book and did a PBS movie called Sick Around the World. And he's just a remarkable man, almost of Bill Moyer's stature. And he's the chairman of the Medicare for All Universal Healthcare movement in Colorado. So this guy's smart, articulate, gives lots of talks. And in this interview, he started talking about the public option. And he was talking positively about it. So I'm using him as an articulate person who is one of our allies. And he said, oh yeah, this idea that Biden has is that we could have this public option. People could buy into Medicare, and Medicare premiums are people, it's like $220 a month or less, and so the premiums are low, and the coverage is great. So a lot of people believe that, and this is a really smart guy. He believed that. And I started trying to explain to him. Then I said, okay, I'm doing an interview with this guy. I don't necessarily want to push back, and it's a short show, blah, blah, blah. But the problems are many. And, they tried to do a public option in 2009 as part of the Affordable Care Act. And surprisingly enough, the insurance companies got onto it. Ha! The insurance company said, this is going to be a slippery slope to single payer. We're going to fight this thing tooth and nail. And they did. And what they first did, they started cutting it and making it less generous and more expensive. And in the end, it didn't even get through the Affordable Care Act bill that time because the insurance companies fought against it. And even if it had, it still keeps a big role for the private insurance companies, which are the problem. And it keeps the system very inefficient. So the public option's it's very tempting, but we need to not fall for it.
Other comments, AJ? And then Lucy.
I'd just like to add to that two things about the public auction. One is during the Democratic campaign for president, So there was the Center for American Progress and like Pete Buttigieg, Medicare for All that won it. It's essentially a public option. They, the industry front groups that had that represent all the worst actors. So pharma, which is the lobby umbrella organization for the pharmaceutical industry. Also the AMA, the hospital organizations all got together and they have this group called, I think, Partnership for America's Healthcare Future, I believe they're called, primarily to avoid to oppose Medicare for All. But they started targeting the public option and Medicare for All that want it. So the idea that watering down our demands to something to moderate it, and therefore the people that oppose Medicare for All will be okay with the moderate compromise, and they'll be placated with the moderate compromise, I think is a bad, not rooted in fact. But also bigger picture, having public option preserves a tiered system where we still have the caste system that Rob made that point earlier. Public option is better than, and allowing everyone to have some sort of coverage is better than nothing, of course, but I want everyone to have what they need. And that everyone's need for healthcare is, everyone has it, doesn't matter who you are unless you have the misfortune to die young. Having a public option preserves this tiered system. And so the example I typically use is South Africa, where there is a public option. So there's public health insurance, but they still preserve the private health insurance industry. And so if you're rich in South Africa, you get private health insurance because it's more generous. And the public option is preserved for the poor. And so it gets starved for resources and doesn't cover as much. And we see this in the United States, of course, with Medicaid, which is the public health insurance for poor people. Well, Medicare is really hard to navigate and it's really stingy and it doesn't cover everything that people need. And it's used as an example for why public health insurance isn't going to be good. Well, of course, it's not going to get funding because it's just for the poor folks that the rich electeds and CEOs don't care about. So in South Africa, they have their public option, but they preserve the tiered system. They also have the tiers of private health insurance for the rich. We can imagine, even after the abolishment of apartheid, what the complexion of people who are in the public option in South Africa versus the people that are in the private health insurance system in South Africa. And so it turns out the majority, I forget the exact numbers now, let's say 2/3 of folks in South Africa are covered by their public health insurance, but they only get 1/3 of the spending. And it's reversed for the other, for private health insurance, it's 1/3 of people, but they get 2/3 of spending. And of course, the people that have the rich private insurance are white, and that the folks that have the public insurance are black. So they've recreated apartheid despite not technically having apartheid. So that's one reason why I am opposed to public option. It just preserves a tiered system. We make the lowest tier, instead of having no insurance whatsoever, you have crummy public insurance.
So we're kind of getting into some of the questions too. So this part was particularly for the panelists to respond to what each other just said, and that's okay if we bridge that. But Riley wanted to say something, and Lucy, and then we'll go into the full Q&A that people have.
Yeah, I actually can, in my comment, respond to something that Rob said. Rob, would you mind putting up the last graph that you put up that showed the quarterly numbers between 2019 and 2020? And it'll kind of go to a little bit what I have to say. But yeah, just to quickly...
I'll put that up.
Thank you. Just to quickly address the public option. Yeah, if you get a chance to check out that document, I agree with all the things said here about it. It's particularly what AJ is saying as far as creating a hierarchical system. And the reason why that happens and why the public option doesn't do what everybody kind of like thinks it will, right? Because we say that it'll be a stepping stone. The reason to Medicare for All, and the reason it won't be, is because the public option, quite frankly, if nothing else that you remember this. It leaves the for-profit system in the driver's seat of our healthcare system. That's it. They're still there. They still get the ability to do their acquisitions and their mergers, and they still can completely control the healthcare system because it's economies of scale. an aside. I want to talk about this really quickly because I think it's a really important thing to point out about our healthcare system, this graph that Rob has. And it brings up one of the clearest contradictions in our healthcare system at all, I think. And it's that the contradiction is, you know, in this past year, during a massive global pandemic, a pandemic which we have not seen the likes of since 1919, the pharmaceutical companies and the insurance companies, but the insurance companies particularly, made more money than in any year prior in profits. So during a pandemic, when people are dying, when people are losing their jobs, when people are sick, when people can't get care that they need because they're afraid to go to the hospital, when our literal healthcare system is crumbling at the edges, they're walking away with the most amount of money they've ever made in history in profits. And the reason is because of all the things that have already been stated on the call, right? That there's doing less elective surgeries. It demystifies a key fact about our for-profit healthcare system, which is that insurance companies make money when they deny care. This graph proves that because they gave out less care in the last year, so they made more money. And that's their business model, right? Like any other insurance company, that is their business model: pay out less and receive less, or pay out as much as least as possible and take in as much money as possible. Yeah, that's all. Thank you.
And
Sure.
let me just make a quick comment. So what I like to say is that if you look at how insurance companies make their money, they're just like any company. They want to try to get as much income and they want to avoid as much expenditure. So they get their income by collecting premiums, and their expenditure is also known as paying for healthcare. So in order to be profitable, which they have to do as a company, they have to figure out either how to get more income or how to have less expenses. And it turns out it's much easier for them to figure out ways to deny care. And they use tremendous amounts of their ingenuity and their brain power and their creativity to figure out how to not pay for healthcare. And I went to medical school to take care of sick people and to give healthcare. And they exist, their function of existence is to not pay for healthcare and not take care of people. So I am just fundamentally opposed to these companies.
Yep. Go ahead, Lucy.
I totally agree. As you know, I'm on the end where I'm with Rob taking care of patients, and you can see when they get less health care, the detriment to their life and maybe the length of their life. That, you know, when the money's going to the CEOs and the insurance companies, and these people are struggling with their chronic illnesses or with an acute illness and getting denied care, getting denied the best care possible because of insurance company profits, we just have to end that.
Okay, so there's also a question about which elected officials support Medicare for all in our county in particular. And I don't think we're going to spend too much time on that, but if someone would like to respond to that, I mean, I think we're in the process of figuring that out.
Yeah, I think we're in the process of figuring it out, but I would say as a start, I do, David Sanders and Nick DeBoer, 3 city councilors.
Yeah, and then if I could just add on top of that, so from canvassing, we've gotten some signatures from local politicians. However, I'd say that we can't be sure until, I mean, really like what shows if someone supports it or not is if they vote for a resolution or like a bill that supports Medicare for all. So.
And I think I'd say on behalf of our committee that we are going to have started to reach out to other local elected officials that are not on the city council, just so because I think that will help if they are willing to make statements. And in the next couple of weeks, hopefully state representatives, state senators, and maybe other county officials we will be able to share statements from them of support. And as we work on that, we'll share that with people. Anyone else want to address that? Okay, so there was a question. Well, sorry. There was a question about how Medicare for All affects the climate compared to our current system. There anyone that wants to address that question?
Well, I could talk about the Green New Deal and why the Green New Deal, in comparison with in companion with Medicare for All, can usher in the sort of the future that we're after, right? I think that there's probably not a super direct correlation, at least that I can draw, as far as it helping the environment. But I will say that, you know, in passing Medicare for All, we plan on doing what's called a just transition. Jim mentioned that as one of the 5 sort of essential components of Medicare for All, and in that there's a just transition to ensure that those folks that are currently holding jobs that keep the status quo intact, that they would get job training, or they would get job replacement, or they would get some sort of just transition. Those things are being written into the bill, and they could very easily get jobs in the green economy with the passage of a Green New Deal. But yeah, that's about as much as I would say on it.
Anyone else want to speak to that question?
I could say something about it.
Go ahead.
It's hard to say what the direct impact would be of a Medicare for All in a vacuum, but one reason why we support it as socialist and say it's a socialist demand is because it builds power of the working class. And so if you think about it, if you have a boss, this gives you more freedom from your boss. This gives you more power compared to your boss. It's going to help unions, people organize unions. If you're already in a union, it's something else that you don't have to worry about if you go on strike, if you're going to lose your health care. You don't have, it's off the table that you need to negotiate for. So if you think that we need to organize the working class to like pass green jobs for all, Green New Deal, do something about climate change, this is going to help us do that in a big way.
Okay, thank you, Jim. Zach has a question.
Yeah, so my question is to the panelists, particularly healthcare professionals. So I was just thinking of when we were talking about your, experiences navigating the system. There's a book I read a while ago, and it kind of deals with planned economies. And one of the chapters was on the British NHS, the National Health Service, I think Dr. Stone talked about before. And so one of the obstacles to implementing the NHS when the Labour Party first took power after World War II was the doctors, by and large, were independent contractors. And so they really strongly opposed being integrated into this new system where they would be public employees. And so my question is for the medical professionals, what is sort of the political economy of being a healthcare employee? Is there an obstacle to be surmounted with some, like say nurse practitioners or specialized surgeons? Are they getting more benefits from a for-profit health insurance system, or are they starting to feel sort of the pressure of market logic? And if there are those sorts of conflicts and contradictions, how do we surmount them? Because I think it's great that we have an NMU is fighting for this. Yeah, sorry if that wasn't very focused, but I'm just curious what your thoughts on that one.
I'm happy to address that unless you want to start, Rob.
Go for it, AJ, and then I'll clean up after the mess you made.
So doctors in general, polling shows that doctors, broadly speaking, support Medicare for all, improved and expanded Medicare for all. But any sort of change is going to have winners and losers. So generally speaking, most doctors, raw numbers, are primary care doctors. And they are not the best paid of doctors. Now, all doctors are well paid, even though we like to bitch and moan about how we want to get paid more. And so my general impression when I've looked at the data, it bears this out. The people that really stand to lose are the ones that are making far and away more than other doctors. So it's the subspecialists when it comes to doctors, so neurosurgeons, interventional cardiologists, et cetera, not primary care, not nephrologists, as it turns out, like me. And so I think overall support is quite positive, but there will be winners and losers. Okay, there's that. And then I think in Indiana, it's actually a really interesting example. So I had prepared some remarks beforehand. I skipped over a bit about doctor burnout because it's just something that's come up recently. We had a lecture last week, an invited speaker to speak at the University of Medicine Grand Rounds about doctor burnout. To me, it's very obvious why doctors are getting burnt out. It's because they're being more and more treated like employees. For the longest time, we've been put on a pedestal, get paid very well. We still get paid very well. But now we're a costly employee, and as the screws tighten, the inevitable logic of profits and costs or income and costs grinds away. Doctors are getting the screws put to us, just like every other employee has since the dawn of capitalism. And we've been kind of exempt, in large part for a long time. We were the capitalists ourselves. We own the practices, but more and more we're just employees like any other employees that are highly respected and get paid tons, but employees. And now that inevitable logic is being, the screws are being tightened on us. So in Indiana, and so I think that's a big part of why burnout's happening. We're being alienated from the work. We feel separated from the noble calling of being a physician and a healer, and we're becoming just getting pressure to produce and make more money and bill. We don't like that, and we're getting burnt out. And it's obvious to me. I don't need more yoga classes. I don't need to be told on my spare time to take time for myself. I need to be able to be a physician and help people out, and maybe have a little bit more time for myself instead of just producing. Okay, Indiana, how things are working out. So the screws are being tightened. And doctors are expensive, so some docs have been laid off around town for no cause, just to cut payroll. So advanced practice practitioners, so nurse practitioners are filling some of these roles they can prescribe. And there's been a movement amongst doctors against nurse practitioners in Indiana, viewing them as trying to claim nurse practitioners are dangerous. But it's obvious to me as a socialist that doctors are just trying to protect our turf, and we're afraid if nurse practitioners who get paid well, but not nearly as well as doctors to do similar work, that we view it as endangering our gravy train. And so what doctors have done is they've tried to block bills in the legislature to allow nurse practitioners to practice more independently without the oversight of a doctor. I've gotten fights with friends of mine over this because they're like, oh no, they'll say that nurse practitioners can't do what a doctor does. And I think that's not often the case. And even if you do think that's the case, we should be banding together with nurse practitioners against the real enemies, which are the bosses, not trying to protect our turf, protect our deck chair of the Titanic that's going down. We need to upend the system itself. It's obvious to me, but it's not unfortunately obvious to most doctors that I've spoken to. Okay, I've talked long enough. I don't know if Rob or Sheila or Lucy.
Go ahead, Rob.
Just a couple things. Yeah, there is some polling. It's not the greatest data. There's generally polling that shows docs in general, 60 to 70% would prefer some kind of universal system, because the docs hate, even the most overpaid specialists still hate it when their patients can't fill the prescriptions and can't make their follow-up visits and can't get their follow-up scans and on and on. So there is an inherent to this whole system. We'd love everybody to be taken care of, even people who I don't necessarily agree with politically. But here's the thing that gives me the most optimism. So the group I'm part of and AJ is part of is called Physicians for National Health Program, PNHP. And I don't even have to write it into the chat. It's just pnhp.org is a great website that is full of an amazing amount of information. And one of the things you'll see about, if you look at the PNHP website, is this thing called SNAP, Students for a National Health Program, SNHP. SNHAP. So SNAP is the student group affiliated with PNHP. And just 6, 7 years ago, there were about 3 or 4 SNAP chapters in the United States, and now there are something like 90. The SNAP chapters are growing like crazy. There's a SNAP chapter in Bloomington. There's a SNAP chapter in Indianapolis. We'd like to spread them to more of the medical school campuses throughout the state. And so when I talk to these medical students, I mean, they just totally get it. I mean, this is not a big stretch for the young doctors, and so that gives me a lot of hope.
Thank you.
Can I add to that real quick?
Yeah.
Just locally. So we had an event with Ed Weisbart with PNHP to come talk on campus in Indianapolis. Rob spoke as well, and it was the room was packed. It was incredible, and just locally without a whole lot of advertisement. And also as a point of hope with this makes me feel old, the younger generation of doctors. So, Rob, you started med school, you said in 73. So for me, it was 20 years ago. So it was 2000 for me. I got gray in my beard, you know. But so I've never joined the AMA. I haven't cared for them. There's been some discussion in the chat. I liked criticizing them. But the AMA, I mentioned, we're part of this, evil lobbying umbrella organization, Partnership for America's Healthcare Future, whatever Orwellian name they chose to oppose actually improving America's healthcare future. They want to preserve their profits. But the AMA pulled out in part because there was a movement amongst young AMA members at the national meeting, Rob's aware of this, to have the AMA endorse Medicare for all. And the vote failed, but only barely, only just. And I think it was a clear message to the AMA membership that they can't be out and out opponents of Medicare for all. So I believe the AMA is no longer part of that Partnership for America's Healthcare Future. And it's because of the young doctors and young members of AMA. So I still haven't joined, but the young folks are going through the quote unquote proper channels and have made some move the ship a little bit.
You know, like AJ, I've never joined the AMA, but I am a member of the State Medical Association, and I've been following what happens in the AMA. And they pulled out of this big coalition. It was a huge step for them, even though they haven't come around to supporting Medicare for all. Other large physician groups like the American College of Physicians has endorsed single payer Medicare for all now. And the other thing about the AMA is that just in the last month, they have named racism as a public health problem. So the AMA is amazing. I'm flabbergasted that the AMA has moved to the left as far as it has, and it's just another sign that you never know where things are going to change and how they're going to change.
Okay, so Aaron has asked the question of what is the point of passing a city council resolution if Medicare for all needs to be passed at the federal level? And Jim is going to address that first.
Yeah, that's a good question. So passing city council resolutions has been one of DSA's Medicare for All strategies, at least a few years going. And so they addressed this question on their website for organizing resources. But to go over that, it's so this is going to be a long-term goal. I mean, the fact that we have a president who doesn't support Medicare for all, and I mean, we'll see like the Senate, but it's important to have some tangible benchmarks along the way. So having like a goal like city council resolutions is a nice way to build momentum. And so like if we could get the more elected leaders even locally, because they may want to move up the food chain, the more we could get to commit to Medicare for all, the better, whether then they want to back away or hopefully lean into it as they campaign up. And also, it seems like out of all the issues, especially of all the issues that we support as DSA, healthcare generates a lot of crossover support. I've even talked to canvassing like self-identified Republicans who support Medicare for all. And so I wouldn't be surprised if we see some Republicans who represent like working class constituents cross the aisle eventually or in the near future. And then third point is that it's been a good opportunity for us, but it'll also be an opportunity. That's something we want to focus on, is using it as a chance to build coalitions with the labor movement, because well, obviously we have NNU, which is great, who's been one of the big pushers of Medicare for all, but there's also the labor campaign for single payer that includes a lot of unions that have locals in Lafayette, such as United Steelworkers, UAW, and the United Auto Workers. And then other points are it builds knowledge and skills in our chapter. I know this has been true for me and like all the people who have been like canvassing with us, like Aaron, who's asked the question, and Adrian and Zach. So like training us to campaign for Medicare for all going forward. It builds relationships in our city, such as like the James Blanco, who's spoken. And final point is it's just like another nice way to kind of flex our power as a chapter. So like working on a tangible and public campaign like this is helps us, like it's given us a reason to host this town hall and have everyone here to learn more about Medicare for all. Oh yeah, Lucy brought up again that it helps build momentum.
I'm not sure if you said this, Jim. I was looking in the chat, but we know that South Bend earlier, this year passed a city council resolution. Bloomington, I think, has passed it at least twice or 3 times. I read that Fort Wayne had, and I know that other cities are working on it, and Medicare for All Indiana is encouraging, among others, various cities in Indiana to do so as well for some of those reasons. And so we hope that and I guess I will say maybe that if West Lafayette passes this resolution, then we hope to help other localities also bring it up.
Yeah, Sheila's like really great that you brought up the point. And yeah, exactly what Lucy was going to say is that this has been like a great way to get in contact with people from all over our state who support Medicare for all, building connections. And one important target coming up for the state of Indiana, I think, will be the our like Indiana 1st Congressional District Representative Frank Mervin, who replaced a co-sponsor of Medicare for All, who retired, Pete Visklosky, and he doesn't support Medicare for all. So I think as we one goal could be as a state to pressure him to support Medicare for all and the Healthcare Emergency Guarantee Act.
Frank, you had a question, and then I think maybe Charles had a question after that. Go ahead, Frank.
Yeah, I just a comment and a question is that I think we often think of Medicare for all as something of critical importance to our most disadvantaged populations, which it is. But I think we should also address how it impacts our entire population. I mean, this COVID pandemic shows the consequences for everyone of not having a logical medical and public health system.
There, for sure.
And yeah, if I may jump in one more time, because we're talking again about the city council resolution, I would plug, we'll have our next big event coming up in January, and we'll also have a flyering December 19th. And we'd love for you to get involved, which you can do at act.gldsa.org. Oh yeah, thanks, Adrian.
Okay, so Charles, you wanted to ask about racism in the U.S. besides Medicare for All. Do you want to expand on that or just have reaction to it? I don't know if Charles is able to hear us. Okay, so he says that as socialists, we often say that reforms aren't enough for overcoming racism, as an example, but why is that?
I'm happy to address that unless anyone else wants to jump in. So I would say that Medicare for All isn't a panacea for racism in the United States or even medical racism. The reasons for that are a few. We talk about the social determinants of health often, and I forget who made the point, but I've heard the point made that it should really be called the political determinants of health. And so often in the healthcare system, we're dealing with problems after they've already started. So we often can't cure them. We just try to manage the problems. And so the point was made that environmental justice is racial justice, which is true. Of course, in Northwest Indiana and East Chicago, there's all sorts of lead poisoning. The example, I believe, of a school built on top of like an old lead smelting plant, something like that. And so those folks, and it's mainly, of course, poor Black folks that were, going to this school and living in this neighborhood, and that's going to cause all sorts of health problems that Medicare for All wouldn't fix. It's other justice issues need to be fixed, housing justice. Of course, the criminal punishment system is horribly racist and causes all sorts of medical problems from that angle, whether it's the stress of living in a racist police state or being actually brutalized by cops. I think in West Lafayette, wasn't there a horrible case of a man's carotid artery being severed by or punctured by a police dog in the last few years, as an example? And so Medicare for All won't solve, housing injustices, won't solve environmental injustices. Also, there are data suggesting that Black folks are less likely to be believed when they complain of pain, when they get less pain medicine. Things like this may not necessarily be solved by universal programs. Although there's a caveat to that. There are some data suggesting at the VA, where I spend most of my time, that outcomes for Black folks after stroke is the one outcome I'm thinking of, I think are equal to or better for Black folks rather than white folks, which is not true for other healthcare systems. So perhaps just having the universal system in the first place can help undermine these racist assumptions that we're all that are we absorb because from living in the society we do. But I don't know that. Oh wow, we have the link to the horrific mauling by the police dog in the chat. And so I think that's why we socialists say that that reforms aren't necessarily going to be everything. We also want to change society, the way people relate to one another. We can't necessarily legislate that. We can maybe make the conditions right. And I think that one of the conditions we need to address is the commodification of health insurance. I would also add that, of course, Medicare for All doesn't eliminate profit altogether. Hospitals and doctors will still be trying to make money. Medicare for All wouldn't change that profit motive for that side. At least from health insurance side, it would be addressed. It would be decommodified. So it's a step on the path. It's one plank, but it's not the whole thing.
Anyone else want to comment on that?
Oh, I would just like to maybe add one more thing. It was a really great question, Charles, and it reminded me that, so national, and answer, AJ. The National DSAs will be releasing their organizing guide for the upcoming year. And one of the platforms for Medicare for All going into the next year is Medicare for All as an anti-racist demand. And Charles brought up a good point on socialist theory of why reforms will not end racism, but you know, Medicare for All and the Healthcare Emergency Guarantee Act are the best policy tools, or if you're thinking of reforms to address racial health disparities.
And I would just encourage people to be in touch with us. There's really a lot of different opportunities to be involved, not just, we'll review them, but not just the things that Jim mentioned in the beginning. We really have different opportunities to work together at this aspect with the City Council resolution, and then continuing on next year to other ways to address these issues. Do we have other questions? No, there've been different comments in the
We're waiting
chat.
on other questions. I would just add one more issue, one more bit of data on the issue, the impact of racism in healthcare in the United States. There are studies, I believe, looking at African immigrants to the United States that move here now, and maternal outcomes, as I recall. So it's well known that, at least amongst healthcare providers, that maternal mortality, of course, is rampantly worse for Black mothers, and so there's debates on and why this is, and so of course I would claim that the lack of Medicare for All and universal comprehensive healthcare system is a major part of it. But interestingly, the data I'm going to share would suggest there's more to it. So these researchers, as I recall, followed women who emigrated from Africa, and their mortality, maternal mortality, I think infant mortality, after moving to the United States was lower. It was not similar to Black folks that have been living here initially. I don't remember what this is my area of research. I don't remember exactly what the limit was. Let's say for the first year, but after they've been living here a while, their mortality rates, maternal mortality rates around childbirth went up, and I think their infant, complications and mortality went up as well. And so the hypothesis is there's just something about living in the United States, being Black, that is hard on your body, right? So maybe it's the police terror, it's the employment discrimination, it's the precarity across the board that you can imagine raising blood pressure and catecholamine levels, all this other stuff. You can make a physiological story for why this is. That's pretty shocking to me outcome that just immigrant Black women, initially same outcomes, but then just living here long enough, it takes a toll on their health. It's just really mind-boggling. Like I said, I think Medicare for All can maybe help that, but I don't think it's not the whole story.
If anyone on the call has experience in the healthcare system related to lack of access or insurance that they want to share right now, that would be fine too, or any other questions, and then we'll go on to maybe wrap up a few minutes early if we're done.
We can give Rob the floor. I'm sure he could fill it in. I could go off the cuff another Medicare
really
for All.
quick, I'm seeing a call from Cassie Norris. I can read it out.
Okay, great.
Okay, so she asks, are there any Medicare for All documents or resources that address restructuring pre-hospital EMS, so emergency medical service, to function as a public utility, from oversight to structure to privatization to billing as a field? We're a mess. So that's a good question.
I could talk about that a little bit. It sounds to me like what you're referring to is the fact that EMS used to be a public utility, not completely a public utility, but in county, the EMS system was run by the county. and subsidized by the county. And what's happened in EMS is that well, now in Bloomington, it's all part of the IU system, so it's become corporatized. But the even bigger problem is that EMS systems, which I mean ambulance services, are being they're private EMS corporation. There used to be a lot of small, like Indiana had a ton of small private EMS systems too that functioned alongside the public EMS systems. Those have all gotten consolidated, and then they've become nationally consolidated. And so now there are a relatively small number of public EMS systems, and then those in turn have now, some of them have been sold to venture capitalists. And what we're seeing is this, profiteering gone wild, profit feeding frenzy, and the way that they make. So how do you make ambulances profitable when you don't have all that many? Maybe a lot of people use ambulances don't have a lot of money, and you can't get a lot of money out of them. Well, what they do is these large EMS systems then do not contract with any hospitals or doctors, and so everybody's out of network, and so everybody gets so these are what's called surprise bills. When you go to you call the ambulance in a lot of places. Not so badly in most of the cities in Indiana, but in some of the rural areas in Indiana. And then the company doesn't recognize your insurance, so they charge you the full thing, and then they'll take you to small claims court, and they'll drive you into bankruptcy over an ambulance bill. And then if you get picked up by a helicopter, it's really, you'll pay $50,000 out of pocket for a helicopter if you have a private, one of these big private ambulance companies picks you up. So, but it wasn't that long ago that most EMS really was kind of run like a public utility. Medicare for All, PNHP, has not taken any official stance, as far as I know, about ambulances, other than we've helped to publicize some of these issues around how there's been so much profiteering being made with ambulance services lately.
Laura, you have something you want to say? Go ahead.
Hi, my name is Laura Marie Williams, and I am a registered nurse working locally here in Tippecanoe County, currently in the emergency department of IU Health. And I'm just wondering, I don't know, suggestions how I kind of get my colleagues more on board, and how I feel out getting doctors I work with on board or involved. And maybe this isn't the arena for you to answer this, those questions, but I don't know, I'm wondering how to just appeal to, I don't know, my colleagues. Yeah, I guess that's my suggestions, and somebody can contact me. I think I'm on the email list if this isn't the arena, but
Definitely the arena.
Yeah, thanks for asking, for sure. And Diane, I don't know if she's still here, who's a family practice physician, typed in the chat a little while ago, and she's interested in working on that. So I think that's something that our chapter can connect you, and that's part of the outreach that we hope to do. AJ?
I'd like to make a plug. So DSA has a national caucus called the Health Workers Caucus, and it's brand new, and includes health workers of all walks. And one of the focuses, they're organized in the national DSA structure in the labor tree, labor organizing tree. So a big focus is labor organizing. So I'll dig up the link and I'll plop it in the chat if you're interested. That's one. Another one is, as I'm sure you're aware, there aren't any nurses unions in Indiana, and a nurse at IU Health was fired. It made national news briefly in Indianapolis. This is a few years ago for trying to unionize, and they canned her. And of course, I mean, we mentioned Dr. Burnout, but I think nursing morale, at least in Indiana and Indianapolis, seems like it's absolutely in the dumps, and that was before COVID. And now, you know, with shortage of PPE, which, you know, typically the choice stuff goes to the docs, you know, before the nurses, and you know, people working whatever longer hours and all the rest. You know, morale just got to be absolutely in the dumps. I would think that it potentially could be an opportunity to help organize, because if workers were organized, then they could make demands of the administrations that have more worker protections, that sort of thing. PPE, staffing ratios, all the rest. Easy for me to say, it's harder to implement. I'm not an experienced labor organizer, so Riley maybe could address that.
I too am not an experienced labor organizer per se. I have my background in electoral campaigns, which is why the nurses brought me onto their national campaign. However, NNU would be perfect people to talk to. So if you're interested, I could absolutely connect you to people in our collective bargaining department that would be totally happy to talk with you about how to have these conversations. They could go so far as, I mean, I could too, and I'm sure other folks on this call too with this DSA chapter with Jim could sit down and help you power map your co-workers and you know, list out, you know, are they one very close to the issue, or are they five really far away, and start with your ones that are a little bit closer, and you know, find the things that appeals to them in the conversation, then use those and other. I mean, it's organizing 101, and it's beautiful and it's wonderful, and I'm so glad to hear that you're here and, you know, taking these first steps. So thank you.
Sounds good. Other closing comments before we turn it to Jim to share some information about our chapter. And I think we'll be in touch with everyone who's been on this call. Rob, you have your hand up?
Yeah. I'll just take a moment if you'll give me a minute for some closing comments. I just really think that I mean, there are a lot of issues, and no doubt the environment is a huge issue, and no doubt things like health, election financing and election and protecting the vote, those are huge issues. But I'm really partial to organizing around healthcare, and part of the reason for that is that well, you know, environmentalists sometimes, or people sometimes make fun of environmentalists and say that they're NIMBY. You know, they're people who got involved in the environmental movement because they were not in my backyard. They're not environmentalists until they find out they got a waste dump outside their door. But everybody has a NIMBY healthcare issue, from themselves, from their friends, their family members, their church members. I mean, everybody knows somebody who's had a healthcare nightmare happen to them. Everybody knows somebody who's got healthcare debt that they have to deal with. Everybody knows somebody who even has insurance and still has a really hard time getting adequate healthcare out of what we got going on right now. So I really think healthcare is the issue that we can organize around and make some inroads. And then after we get health insurance for everybody, then maybe that'll soften other issues up, and we can do better on the environment, and we can do better on campaign finance reform and all these sorts of things. But the last thing I want to say is I want to go back to AJ. Actually, he said, Medicare for all is necessary but not sufficient. And that's actually a quote from Marcia Angel, who's one of my heroes and mentors. She was the first woman to become the editor of the New England Journal of Medicine, which is the United States' maybe the world's most prestigious medical journal. Marcia Angel used to speak regularly at the PNHP meetings, and she'd say, Medicare for all is necessary but not sufficient. There's lots of other problems we got to deal with. So we got to get Medicare for all done, and then we can work on a lot of other stuff. And without diminishing that at all, I also got to say that racism is one of the biggest problems that we are all facing right now, and we have to keep facing, and we have to keep figuring it out how we're going to make some progress in this. And so, to me, like, one way to look at healthcare for all is to say this would be like the minimum step for reparations. This would be like the minimum step to begin the process of healing people, because we as physicians and nurses and patients, we all know that you can't get people healthier if they can't get food. They live in a food desert, and if they don't have housing, and if they're insecure and scared, and if they're Black and afraid they're going to get killed by the police, and on and on and on. So there's a lot of work to be done. And I love organizing around healthcare. Luckily, it turns out I'm a doctor, so maybe that gives me some other advantages. But everybody can do it, so I'm all for it. We're going to win this thing eventually, and I'm really happy to see this good crowd of folks here and hear about all the work that's going on. Yeah, I just love being here tonight.
Okay, well, I think we've had a very informative and engaged discussion, and we look forward to continuing to work with many of you in one capacity or another. And Jim is going to talk a little bit about some upcoming events for Greater Lafayette DSA.
Thanks, Sheila. Yeah, so if I could see. Okay, so yeah, last time, I said we'd love if you get involved. To be honest, like, we really need as many people involved as possible. Like we said, it's a mass member or mass organizing. So even a few more people would really build or help us do so much more. And please consider joining DSA. We have Saturday, December 12th, for those people on this call from Indianapolis, or if you want to drive, we'll have a cancel rent protest outside of Governor Holcomb's mansion. This is another one of our campaigns that we have as a chapter, is housing. So this should be a pretty good event or way to get involved. And then finally, Tuesday, December 15th, we will have, I think this is our first, Socialist Night School. And we have a pretty cool guest, David Cabe from Metro DC DSA, who's super knowledgeable. He'll talk about this very topical topic, police and prison abolition. I think a lot of people have different ideas or misconceptions about what it is. So we've invited David Cabe to talk about what police and prison abolition is, and how to, end the state violence that we've witnessed last summer. So please sign up at learn.gldsa.org. And finally, again, please consider joining DSA. And thank you, everybody, for attending this town hall. I hope it was I stopped sharing my screen. Yeah, I hope you had as good of a time as I had. And solidarity. Good night.